In case of acid-base disorder, you know, most important portion is that is the pH and also bicarbonate and partial pressure of carbon dioxide. This is very important. And you know that for acid-base disorder, we actually require arterial blood gas analysis. So this is very important, arterial blood gas analysis. Now, what is acid-base disorder? You all know that is an acid-base disorder is a change in the normal values of extracellular pH. That may result when renal or respiratory function is abnormal or when an acid or base load overwhelms the excretory capacity. So most important is normal respiratory and renal function. So this is very important, and you know that is the normal acid base value is that is also, so it is very difficult because many students are coming later. So actually it is very difficult to admit all these students at a time. So in case of normal acid base value, that is the, you have to look for the range of pH. You know the pH is 7.35 to 7.45, and you have to know the partial pressure of carbon dioxide, that is 35 to 45, and the level of bicarbonate level is 20 to 26 milliequivalent per liter. And you know this pH value, optimum value of pH is 7.4, and the partial pressure of carbon dioxide is 40, and bicarbonate is 24 milliequivalent per liter. So clinical disturbance of acid-base metabolism classically are defined in terms of bicarbonate and carbon dioxide buffer system. Now comes to the, in order to approach acid-base disorder, consider the following equation. You all know that is the Henderson-Hasselbalch equation. You have already been taught in the biochemistry classes. That is pH, that is most important part. That is 6.1 plus log of bicarbonate divided by 0.3 into partial pressure of carbon dioxide, where 6.1 is it is the pKa, that is the negative logarithm of the acid dissociation constant. It is constant 6.1. For carbonic acid, that is N 0.03, it is a factor which relates to the partial pressure of carbon dioxide to the amount of carbon dioxide dissolved in the plasma. And another simple equation is the Kayser-Blaise equation, that is hydrogen concentration is equal to 24 into partial pressure of carbon dioxide divided by bicarbonate. So in acid-base disorder, as you know, that is the main disorder is metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis, and there is a mixed disorder. So this is very important. Now comes to the respiratory acidosis. In case of respiratory acidosis, as you know, partial pressure of the carbon dioxide will be more than 45 millimeter, and pH is less than 7.35. It is due to the inadequate alveolar ventilation. So if there is inadequate ventilation, carbon dioxide will be retained, that will create carbonic acid, and by dissociation you will get excess carbon dioxide. What are the causes of acute respiratory acidosis? It is mainly alveolar hypoventilation and increased carbon dioxide production. And what are the causes of alveolar hypoventilation? Most important cause is central nervous system depression, neuromuscular disorder, chest wall abnormalities, pleural abnormalities due to pain, say pleurisy and others, airway obstruction, parenchymal lung disease, and ventilator malfunction. So in case of parenchymal lung disease, say in case of emphysema or chronic bronchitis, there is a diffusion abnormality. So carbon dioxide is retained and carbon dioxide level will be increased. So this is the that is carbonic acid level is increased and carbon dioxide level will also be increased. So another cause is increased carbon dioxide production. That is the large calorie load, malignant hyperthermia, intensive shivering, say in the cold season, prolonged seizure activity when there is epilepsy, thyroid storm and extensive thermal injury. So there is increased carbon dioxide production and subsequently bicarbonate level will be increased. So manifestation. What about the manifestation of respiratory acidosis? Mainly the neuromuscular manifestation due to carbon dioxide narcosis. That is that the features will be anxiety, headache, lethargy, stupor, focal paresis, tremor, and asterexis. That is you will get is also in the hepatic encephalopathy. That is a flapping tremor, and there is also delirium, myoclonus, seizures, and coma. So you can, these features are mainly the neuromuscular features. Then how to correct the respiratory acidosis? Management involves correction of the causative factor where possible, but ultimately ventilatory support may be required. Now comes to the respiratory alkalosis. When partial pressure of carbon dioxide will be less than 35 millimeter of mercury and pH will be more than 7.45 due to excessive alveolar ventilation, respiratory alkalosis will result. Now comes to the respiratory alkalosis, that is a central respiratory stimulation due to structural causes like head trauma, that is head injury, or tumor in the brain, or cerebrovascular accident, or non-structural causes, that is the due to pain and anxiety. Due to pain and anxiety, also fever and voluntary causes. And there is also peripheral respiratory causes, that is due to hypoxemia. If there is any kind of hypoxemia, that will cause the reflex stimulation of the respiratory center via the peripheral chemoreceptors. There may be the ventilation perfusion mismatch, pulmonary diffusion defect, hypotension, pulmonary shunt, and in high altitude. In case of high altitude, there will be hypoxia that will stimulate the respiratory center. And peripheral receptors are also marked in the, say, in case of lung. So in this COVID situation, where there is a pneumonia, and there is also other changes. So respiratory center will be stimulated by the respiratory, that is peripheral chemoreceptors. And intrathoracic structural causes, that is the movement of chest wall and diaphragm and compliance of the lungs, irritative lesion of the conducting system, and others, heat exposure, also the sepsis, pregnancy, and metabolic ventilation. So what are the manifestations of respiratory alkalosis? Mainly neuromuscular, lightheadedness, confusion, decreased intellectual function, paresthesia, circumoral or extremities, muscle twitching, cramps, tetany, hyperreflexia. There may be also syncope and seizure. So even circumoral, you will get circumoral tingling and numbness in and around the oral cavity. So these are the features of respiratory alkalosis. And next is how to correct the respiratory alkalosis. Management involves correction of identifiable causes, reduction of the anxiety, and a period of rebreathing into a closed bag to allow the carbon dioxide level to rise. Even in case of hysterical ventilation, you can allow this technique. That is that in a closed bag, patient will rebreathe. So their carbon dioxide level will be raised. Now comes to the metabolic acidosis. This is very important. In case of metabolic acidosis, most important changes is in the bicarbonate level. And you will get bicarbonate level will be less than 22 milliequivalent per liter and pH will be less than 7.35. What about the pathophysiology? In case of renal or GI loss of bicarbonate, say in GI tract, if there is a diarrhea, say acute watery diarrhea, you will loss of bicarbonate. And if there is any decreased renal excretion, there will be also accumulation of acids. Increased production of non-volatile acids like the keto acids, lactate, poisons, and exogenous acids. Say keto acids in case of diabetic ketoacidosis. Now comes to the causes of metabolic acidosis. This is very important. This disorder is divided into normal anion gap and increased anion gap acidosis. Anion gap is the difference between cations and anions. In case of normal anion gap, in case of normal anion gap, that is ingestion or infusion of inorganic acid, that is therapeutic infusion or poisoning with ammonium chloride or hydrochloric acid, gastrointestinal bicarbonate loss, as in case of diarrhea, small bowel fistula, urinary. Okay. Then if there is any gastrointestinal loss of bicarbonate, say in case of acute diarrhea, acute losses of electrolytes, mainly the bicarbonate, and there if there is any small bowel fistula or any urinary diversion procedure, there will be loss of bicarbonate and you will get the metabolic acidosis. In case of renal tubular acidosis, there is urinary loss of bicarbonate in proximal renal tubular acidosis, impaired tubular acid secretion in distal renal tubular acidosis. You will get loss of bicarbonate in the urine and there is resulting in metabolic acidosis. So there will be normal anion gap. Normal anion gap usually 12 to 16. But if there is any increased anion gap, that is endogenous acid load. Say in case of diabetic ketoacidosis, you will get more ketone body, more accumulation of ketones with hyperglycemia. There will be the starvation ketoacidosis, accumulation of ketone without hyperglycemia. There may be the lactic acidosis, that is shock in liver disease, and renal failure, that is accumulation of organic acid, both AKI and CKD. So there will be accumulation of acids. So there will be increased anion gap. And exogenous acid load in aspirin poisoning, accumulation of salicylates, methanol poisoning, accumulation of formates, and ethylene glycol poisoning, accumulation of glycolate and oxalate. So what are the ketone bodies? You all know that is acetone, acetoacetic acid, and beta hydroxybutyric acid. In case of salicylate poisoning, that is also associated with respiratory alkalosis, and also they may develop the hypocalcemic tetany. So, what are the manifestations of the metabolic acidosis? In case of cardiovascular, there is impaired cardiac contractility, that is, and also the pulmonary vascular resistance also increased, and resulting in decrease in cardiac output. So blood pressure, hepatic and renal blood flow will be decreased, and this condition also there is sensitization to reentrant arrhythmia, that is they are very much arrhythmia prone, and reduced threshold for ventricular fibrillation. So in metabolic acidosis, you will get less cardiac output, so blood pressure will be dropped, and there will also decrease renal blood flow, and these patients also susceptible to develop recurrent arrhythmia, and also they may develop ventricular fibrillation. and the responsiveness to catecholamines, that is norepinephrine, adrenaline, will be less. So you will also get less changes in the pulse rate. And what are the changes in the respiratory system? You will get the hyperventilation, and strength of the respiratory muscle will be decreased, and there will be more muscle fatigability, and there is also dyspnea. In case of CNS, there is a inhibition of metabolism, and mental status will be changed. This patient will be more, that is, there is somnolence, and they may develop pre-coma and coma. So what are the changes in the metabolic changes? Increased metabolic demands, insulin, there is also increased insulin resistance, inhibition of anaerobic glycolysis, reduction in ATP synthesis. There may be also the hyperkalemia due to shifting of cellular shape. That, as you know, that is intracellular level of potassium is much more. So potassium will be shifted to the extracellular space, and there is also increased protein degradation. So what are the management principles of metabolic acidosis? First, you have to identify the underlying cause, and underlying cause should be addressed first. Say, in case of diarrhea, you have to manage this patient with fluid. In case of diabetic ketoacidosis, you have to manage the fluid balance as well as the hyperglycemia. You have to treat the hyperglycemia with insulin, and then you have to correct body system will correct this acidosis. So stopping the drugs, that also removes the stopping the drugs that might cause this condition, and using the dialysis to remove this toxin. Since metabolic acidosis is frequently associated with sodium and water depletion, resuscitation with intravenous fluid is often needed. Say, you see, in case of diabetic ketoacidosis, you see, we have to manage in 4 aspects. That is the fluid balance, management of hyperglycemia, management of electrolytes, that is, these patients are frequently associated with hypokalemia. Then if not corrected, then you have to address the metabolic acidosis by infusion of the bicarbonate. So underlying cause should be treated first. This is very important. Use of intravenous bicarbonate in this setting is controversial because rapid correction of acidosis can induce hypokalemia or fall in plasma ionized calcium. The use of bicarbonate infusion is best reserved for situation where the underlying disorder cannot be rapidly corrected and acidosis is severe. Say hydrogen concentration more than 100 millimole per liter, or pH is less than 7, or associated with evidence of tissue dysfunction. In that particular case, you will use the bicarbonate. Otherwise, the principle like that of the diabetic ketoacidosis, you have to treat hyperglycemia, you have to replace the volume replacement, you have to address the electrolyte imbalance, then you have to give the bicarbonate if not corrected. So a specific therapy of metabolic acidosis, replacement of the existing fluid deficit as a result of hyperglycemic osmotic diuresis, as well as insulin, potassium, phosphate and magnesium. In case of lactic acidosis, restoring adequate oxygenation and tissue perfusion is important, and the anaerobic glycolysis should be stopped. In case of salicylate toxicity, alkalization of the urine with sodium bicarb to pH more than 7 increases its elimination. Now comes to the metabolic alkalosis. So you are seeing when bicarbonate level is more than 26 milliequivalent per liter and pH is more than 7.45. So in case of metabolic acidosis or alkalosis, bicarbonate is very important. If it is high, then it is alkalosis. If the bicarbonate level is less, it is acidosis. and pH will be more in case of alkalosis, pH will be less in case of acidosis. So these will move in the same direction. Now comes to the pathophysiology. In case of metabolic alkalosis, there will be more bicarbonate level, and there is hydrogen loss either from the renal system or from GIT. Hydrogen ion will shift from intracellular space to extracellular space, and there is a contraction of the volume or chloride diffusion. Say, in case of profound vomiting, there will be loss of hydrogen ion, and resulting in there will be more dissociation of the carbonic acid, and bicarbonate level will be more, and so there will be the metabolic alkalosis. So you have to consider the underlying cause. What are the causes of metabolic alkalosis? One is chloride sensitive and one is chloride resistant. In case of chloride sensitive, gastrointestinal, that is vomiting, gastric drainage and diarrhea. In case of, we are frequently using diuretics, that may also cause metabolic alkalosis. And in case of cystic fibrosis, there will be loss of the loss of sodium and resulting in also gain of bicarbonate. In case of chloride resistance, you will see primary hyperaldosteronism, and there is edematous disorder that is resulting from, say, congestive cardiac failure or cirrhosis of liver. There will be the chloride easily resistant, and there will be Cushing syndrome and severe hypokalemia. And other miscellaneous cause of metabolic alkalosis is, say, massive blood transfusion, acetate containing colloid solution, alkaline administration with renal insufficiency with alkali therapy, combined antacid and cation exchange resin therapy, and in case of hypercalcemia, there is a milk alkali syndrome and bone metastasis. And in case of, that is some drugs which is also rich in sodium content, and also the glucose feeding after starvation may result in metabolic alkalosis. Now comes to the manifestations. That is cardiovascular manifestation. There will be the arterial constriction, reduction of the coronary blood flow. So angina may precipitate. They may precipitate the arrhythmia, that is refractory supraventricular arrhythmia can occur, and also there may be respiratory hyperventilation, that is compensatory hyperventilation to raise the carbon dioxide level. There may be hypercapnia and hypoxemia may there. Now comes to the, what are the metabolic changes? Stimulation of the anaerobic glycolysis or organic acid production, reduction of the plasma ionized calcium concentration. So in case of metabolic alkalosis, you will see ionized calcium level will be reduced, resulting in tetany. In case of hypokalemia, secondary to cellular shift, and there may be hypomagnesemia as well as hypophosphatemia. So if there is any persistent hypokalemia, one should think whether there is any hypomagnesemia. In case of cerebral manifestation, there is a reduction of the cerebral blood flow, so there will be mental status will be changed. There will be the stupor, lethargy, and delirium, and there will be also neuromuscular irritability related to low ionized calcium level, that is tetany, hyperreflexia, and there may be a seizure. So these changes can occur in metabolic alkalosis. Now this is a very important slide, that is the generation and many maintenance of metabolic alkalosis during prolonged vomiting. This is a commonly asked questions in the exam. So you see, if there is a vomiting, prolonged vomiting, first change is gastric loss of sodium and chloride. So sodium chloride will be lost, and there may be hypovolemia. Hypovolemia resulting in renin-angiotensin aldosterone system will be activated. There will be the proximal sodium bicarbonate reabsorption will be increased, resulting in metabolic alkalosis. There is also loss of hydrogen and chloride. that is metabolic alkalosis, resulting in more metabolic alkalosis. There will be also loss of potassium and chloride, resulting in hypokalemia, and which results in that is distal hydrogen ion secretion will be increased and more hydrogen ion secretion in the urine. So this is overall pathophysiology in case of prolonged vomiting. So in case of prolonged vomiting, you will get metabolic alkalosis, but reverse is prolonged diarrhea. There you will get metabolic acidosis. So how will manage a case of metabolic alkalosis? Metabolic alkalosis with hypovolemia can be corrected by intravenous infusion of 0.9% saline with potassium supplement. That is crystalloid solution you will give. That is 0.9% sodium chloride is enough, and potassium if required. This reverses the secondary hyperaldosteronism and allows the kidney to excrete the excess alkali in the urine. Because if there is hypovolemia, that is the renal perfusion will be less, renin angiotensin aldosterone system will be activated, and this if you there is a fluid replacement, this secondary hyperaldosteronism will be reversed. In metabolic alkalosis with normal or increased volume, treatment should focus on the management of the underlying endocrine cause. Say, in case of prolonged vomiting in gastric outlet obstruction, main management will be the replacement of the sodium chloride by crystalloid solution, 0.9% sodium chloride solution. That will, if renal function is okay, that will automatically it will correct the situation of metabolic alkalosis. Now, how to diagnose acid-base disorder? This is very important. You see, in case of metabolic acidosis, blood hydrogen ion will be more. That is 40 nanomole per liter. It is equivalent to 7.4. And what about the bicarbonate level? As you already mentioned, bicarbonate level will be less than 24 millimole. And compensatory response, that is carbon dioxide, partial pressure of carbon dioxide will be less than 5.33 kilopascal. In case of metabolic alkalosis, that is hydrogen ion concentration will be less, but the pH will be more than 7.45, and bicarbonate level will be more than 24 millimole. And in case of respiratory acidosis, that is blood pH will be more than 40, that is more than 7. That is hydrogen concentration will be more, but the carbon dioxide partial pressure of carbon dioxide will be partial pressure of carbon dioxide will be more than 5.33 kilopascal. And respiratory acidosis, that is it will be alkalosis, blood pH will be less than 40 and carbon dioxide will be less than 5.33. So this is an important E. Now comes to the stepwise analysis. Someone is in the waiting room still. Okay. Stepwise analysis. So first important thing is details history and physical examination. You will look for the clue for acid-base disorder. Verify that the lab values are consistent. Each pH is low, normal, or high. This is very important. You first you have to look for pH. If pH is less than 7.35, it is acidosis, either respiratory or metabolic. Is the primary disturbance of metabolic or respiratory? If both are abnormal, pick the one that seems most severe at first glance. Is the disturbance acute or chronic? Have compensatory changes occurred? For metabolic acidosis, what is the anion gap? This will help to develop your list of differentials. Is there a secondary or tertiary disturbance present? So you have to analyze these things. So there are some clue. This is very important. If there is a prolonged vomiting, What will be the change? That is the metabolic alkalosis. If there is a history of diabetes, if there is a diabetic ketoacidosis, this is metabolic acidosis. If there is a history of smoking and chronic obstructive pulmonary disease, it is likely due to respiratory acidosis. If there is a history of liver disease, it is likely respiratory alkalosis. Recent binge drinking, likely metabolic acidosis. If a person take constant drink of alcohol, that may result in metabolic acidosis. In case of diarrhea, there is a metabolic acidosis. In case of tachypnea, there will be the respiratory alkalosis. In case of hypotension, there is usually metabolic acidosis. Say in case of cardiogenic shock or in a peripheral circulatory failure, the resulting in metabolic acidosis. Now this is a very important clue. Look, first you have to look at the pH. Any deviation from the normal? If there is a reduced pH, that is less than 7.35, it is likely due to acidosis. Then it is uncompensated disorder. If pH is high, say more than 7.45, it is due to alkalosis. Then it is due to uncompensated disorder. But if pH is in the normal range, that is between 7.35 to 7.45, then there must be either no disorder or compensated disorder. That is, body has tried to compensate to back to normal. Now grading, this is important. In case of acidosis, mild acidosis is 7.3 to 30 to 7.34, moderate 7.20 to 7.29, and severe less than 7.2. But when the pH drops below 6.8, it is incompatible with life. So you have to be very careful when there is a severe acidosis. Similarly, if there is alkalosis, in case you label it as a mild alkalosis, if pH is 7.46 to 7.50. In case of moderate, 7.51 to 7.54. In case of severe alkalosis, that is more than 7.55. But if the pH is more than 7.8, it is incompatible with life. So this is very important. So now comes to the analyze disorder, whether respiratory or metabolic. In case of respiratory disorder, if pH and partial pressure of carbon dioxide move in the opposite direction in relation to normal value, this is important. This will, in case of respiratory cause, pH and PaCO2 will be moved in the opposite direction. In case of metabolic disorder, pH and PaCO2 will be moved in the same direction. Now you see, in case of primary respiratory acidosis, the pH will be less, but PaCO2 will be moved up. In case of primary respiratory alkalosis, pH will be high and PaCO2 will be less. It will in downward direction. In case of metabolic acidosis, pH will be less, but PaCO2 will be also less. So this is the same direction. In case of the primary metabolic alkalosis, pH and PaCO2 will be moved in the same direction. So the message is, if pH and PaCO2 move in the opposite direction, it is due to the respiratory acidosis or alkalosis. It move opposite direction. But if pH and PaCO2 moves in the same direction, it is either metabolic acidosis or metabolic alkalosis. So this is very important clue. Evaluate compensation and correlate pH, PaCO2 and bicarbonate. With time, body tries to bring pH towards normal. Lung and kidney are primary buffer response system. Primary respiratory acidosis, as already been mentioned, pH will be less, PaCO2 will be more, and more bicarbonate will be there. In case of primary respiratory alkalosis, pH will be high, PaCO2 will be less, and bicarbonate will be less. you are seeing that both PCO2 and bicarbonate usually moves in the same direction. In case of the primary metabolic acidosis, pH and PCO2 will be moved in the same direction, that it will be less, and bicarbonate will also be less. In case of the primary metabolic alkalosis, pH and PCO2 will be in the same direction as well as bicarbonate in the same direction. So bicarbonate and PCO2 will always move towards the same direction. So if you can if you can remember this thing, you can easily interpret in which condition it is. Then points to remember: in case of respiratory acidosis, primary change in the partial pressure of carbon dioxide that leads to decrease in pH. For each 10 millimeter mercury changes of partial pressure of carbon dioxide, pH usually falls by 0.05. For respiratory alkalosis, primary change is in the partial pressure of carbon dioxide, that is, it usually lessen and leading to increased pH. For each 10 millimeter mercury change of PCO2, pH will be moved by 0.1. In case of metabolic acidosis, primary change in the bicarbonate or hydrogen ion leading to less pH. For changes of bicarbonate, if it is lessened by 7 to 7.5 milliequivalent per liter, pH will be dropped by 0.1. In case of metabolic acidosis, primary change in the bicarbonate, that is bicarbonate level will be increased or hydrogen ion concentration will be less, leading to increased pH. For bicarbonate level, if increase of 7.5 milliequivalent per liter, pH will be more by 0.1. So this is very important clue if you can remember. So this is all about today's presentation. So if there is any question, you can just unmute, and you can unmute yourself and you can ask the questions. Okay.